طبعا هنشوف الموضوع ده كله في السلايدز الجايه. This is the patient assessment. طبعا I'll not go deep in history taking. المفروض انتم عارفينها اللي هي standard history، يعني nothing more nothing less. History taking is the standard classic history taking, nothing more nothing less. طبعا عندنا patient assessment we have to consider special issues, especially in the patient examination. We have to I mean the patient, the history taking, we have to obtain the cardiovascular history, respiratory history or respiratory system history, past history, and drug history. Cardiovascular history is important before surgery. Why it's important before surgery? Because the patient might have or may have high risk issue for this procedure. For example, patient with congestive heart failure, patient with atrial fibrillation, for example. ما هو نفس المريض الطبيعي. ما هو it's not the same like the patient is having nothing or the patient is cardiovascularly free. ما هو نفس الشيء. It's not the same plan for anesthesia. It's not the same plan for surgery. So cardiovascular surgery is important, and you should consider this before surgery. Okay, you should obtain cardiovascular history before any surgical procedure. Okay, as well as the respiratory system history. Past medical history يهمنا فيها أشياء معينة، مو زي الباست ميديكال هيستوري تبع الانترن ميديسن. No، يهمنا فيها الأشياء التالية. مثلا past surgery or previous surgeries is important. History of allergy is very important as well. عندنا history of drug history حنيجي فيها. إذا عندنا past surgery, past history of surgery, or any previous surgeries, any previous exposure to the anesthesia. تمام. و medical history حنخش فيها أتوقع أكثر من كذا. عموما past history is not like the past history of the internal medicine. We should focus on the previous surgery and exposed to the anesthesia. Okay. Drug history is very important, and it's crucial. Patient on certain medication should be stopped before surgery. Like what? ممكن أحد يشاركني في الشيء هذا؟ ممكن أحد يقول لي إيش drugs that you should stop before surgery? And you have one patient, he came to you with, for example, hypertension and diabetes mellitus. These are the most common conditions that we face daily in the OBD. So you ask him about medication, and you found that the patient has certain medication that you should stop before surgery. What are they? Warfarin. So anticoagulation. Excellent. For warfarin, we will go through it. We should stop anticoagulation before any surgery. This is a general rule. Either we stop it, or we can change to another. We can put the patient on another anti-coagulative medication or anticoagulation that has a very short life, very short half-life. Okay. Ibuprofen, actually no. Ibuprofen, it's not the medication that you should stop before surgery. What others other than anticoagulation? What else? Should we stop beta blockers before surgery in patient, for example, patient with hypertension? He's on labetalol, for example, beta blocker. Should we stop that medication before surgery? Should we stop beta blockers before surgery? The answer is no. We should continue the beta blockers even before surgery. It's there's very important point that, for example, the patient came to you in the ER. Let us talk about the emergency case. For example, patient came with acute cholecystitis, and he is in sepsis or septic shock. Sepsis, the first sign of any shock is tachycardia. Tachycardia. This patient came to you with acute cholecystitis. He has white cell count of 30, for example, for 30,000, for example. So he's in sepsis, but his heart rate is normal, or he is a little bit bradycardic. What is the cause? So because this patient, he might have some antihypertensive medication that will mask the tachycardia. So the importance of beta blockers, you should know that the beta blocker can mask the tachycardia in case of any shock, or in case of septic shock, or hypovolemic shock. And the beta blocker should not be stopped before surgery. What other medications يا شباب? Should we continue the ACE inhibitors, for example? Angiotensin converting enzyme inhibitor. It's a treatment. It's one of the medication of hypertension. Should we stop that medication before surgery? The answer is no, because the patient might develop hypertensive crisis during OR. So what else? Chemotherapy. Is it important to know that this patient is on chemotherapy or not? It's very important. It's crucial. Especially if the patient is undergoing a GI surgery, for example, and you need to resect a small segment of the bowel, and you need to create, or you need to do anastomosis. So the patient on chemotherapy, should we proceed for anastomosis or not? The answer is no, because the healing process will be affected by these chemical drugs. So chemotherapy will affect the surgery. هذه أمثلة في طبعا المفروض انكم you go through it, and you can search for that medications that we should some surgeon should stop, or someone should stop it before surgery. So the principles of history taking is, you have to listen to the patient. You should, first of all, you should give open questions. So you ask the patient, what's your problem? And let the patient speak, and listen carefully to him. After that, إذا كان الحوار معك طلع من مجال الجراحة، خلاص. This time you should start giving a closed question, yes or no question. Okay? And then to narrow your differential diagnosis, you have to focus on specific question. And for all comorbidities, they have fixed question. For example, ناخذ مثال بالعربي. جاني مريض قال لي والله أنا عندي ألم، عندي المرارة. إيش عندك يا والد؟ قال لك عندي المرارة. والله تجيني من فترة لفترة وما أدري إيش، ورحت المستشفى الخاص وسووا لي أشعة وبدأ يتكلم. أنت هنا you should give immediately close question. متى جاتك ايش المشكله اللي عندك؟ هل تحس بالم؟ متى يجيك الالم؟ بعد الاكل ولا قبل الاكل؟ وتبدا تاخذ الهيستوري حقك بكروس كويشن، يس نو كويشن. and then you focus مثلا على المراره، you focus on gallbladder disease and its symptoms. and then for comorbidities، هل يا والد عندك ضغط؟ هل عندك سكر؟ هل عندك امراض في القلب؟ عندك امراض تنفسيه؟ دخلت عمليات قبل كده؟ تمام. so it's a fixed question. في اي استفسار الى الان؟ في أي سؤال، أي استفسار، أي شيء واضح ما قلته، أو أي شيء واضح أي شيء ما كان واضح أنا قلته؟ الأسبرين، فيما يتعلق بالأسبرين، طبعا most of the hospitals in our region, they stop aspirin before surgery. From where I came from France, they don't stop aspirin, the regular aspirin. I mean that of 80 milligram or 75 milligram. They don't stop aspirin in such doses before surgery. But for 300, for curative dose, 300 milligram, yes, this one should be stopped before surgery. So the patient with low dose aspirin, for example, 75 or 100 milligram, it's fine, it's okay. We can proceed for surgery. But for 300 milligram, it's too much, and this one should be stopped before surgery. في سؤال آخر؟ طيب, we proceed. For examination, like any examination, you have to obtain vital signs first, and then you proceed your exam from head to toe. You start from the hand, like any physical exam, and you proceed for cardiovascular, respiratory, GI exam, neurological. We don't focus on that in that exam, except for the neurosurgery procedure. Okay, and regarding the air assessment, actually, we as a surgeon, actually I don't assess the patient for airway. The one who is concerned about that is the anesthesia. It's not part of our exam as a surgeon, but we can ask them roughly certain question that exclude any airway uh, uh, obstruction or any difficulties that the anesthesia will face during intubation. Again, this is the examination general. Positive finding, even if not related to the proposed procedure, should be explored. Surgery related, you should actually explain to the patient the site of surgery, the type of surgery, the complication that could happen before after surgery, and then systematically you should explain the effect of his comorbidities on this surgery. Okay, specific, for example, suitably for positioning during surgery. If the patient, for example, is having bilateral, for example, total knee replacement surgery, so the patient has bilateral prosthesis, and you need to put him on certain position on the table, and you need to ask the patient if he has a limitation of the movement of his both knees. This is an example, huh? Both knees, or he cannot flex or extend his knees, for example. This is an example. So you should ask the patient about uh, 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 any implant or uh, uh, any difficulties that you will face during positioning the patient on table. Examination specific to surgery, the clinical finding, as I said, site, specific imaging or investigation findings related to the pathology for which the surgery is proposed should be noted. Okay, so the source of potential bacteremia can compromise surgical results, especially if the artificial material is implanted. For example, if the patient is having hernia, we know that the patient, for example, the most common approach or the most common technique using or used during hernia repair is mesh repair. So you put a mesh. If you will put a mesh, the mesh is a foreign body, and if the patient is having diabetes, for example, diabetes or hypertension or immunocompromised patient, this those patients will have a risk for implant infection. So you should explain thoroughly uh, the risk of infection of this implant. Actually أنا شخصيا أنا مثلا المش عندي مش المش اللي هو الدعامة. انتم ما انتم معنيين بهذا الشيء في الأسنان، لكن هو عبارة عن دعامة تتعمل اثناء اثناء عمليه الفك، تنحط على الفاشل for reinforcement of the anterior abdominal wall. فاحنا انا عندي شخصيا عندي وصله من هذه الدعامه في العياده، اوري فيها المريض. اول ما يجي اقول له يسالني عن الدعامه، ايش الدعامه؟ اقول له هذه الدعامه هي عباره عن جسم غريب ينحط في مكان العمليه. وممكن بعض الناس ترفض هذا الشيء، اجسامهم ترفض هذا الشيء فيكونوا عليها التهاب، واحتمال انه يصير فيها خراج ونرجع نشيل الامبلانت. So you should explain everything to the patient، لانه المريض كل ما شرحت للمريض، كل ما دخلت في تفاصيل العمليه، كل ما اعطيت حق المريض، كل ما وثق فيك المريض. So such as in joint replacement surgery or arterial grafting, so you should explain everything. Check for the check and treat infection and the pre-operative period, any infected tooth. Anyhow, the patient should be out of any I mean he's not in any acute phase of any infection, or he's not in acute phase of any medical problem. For example، يعني ما تدخل لي المريض، ما تدخل لي العمليات واحد عنده دي كي for example for elective case. I mean الحالات الباردة، يعني أنا ما أدخل مريض العملية وهو عنده upper respiratory tract infection for example. You should treat this before surgery. Okay, so the patient should be prepared. This is what's called preparation before surgery. That's why the history and physical exam is important before surgery. طيب, next, investigations. There is certain investigation that you should do before any kind of surgery, especially for general anesthesia surgeries. If the patient will undergo general anesthesia for certain surgical procedure, you should consider certain investigation. Full blood count, CBC, is important. Why is important? Why you should order CBC for each surgical patient? Okay, excellent. For to detect the hemoglobin before surgery. Okay, what else? Yes, white cell count. Exactly. So you should look for white cell count, because if it's elevated, that means the patient is having an infection, is having an infection, or there's a focus for infection that you should treat before surgery. Platelet count is important before surgery. What else? I think that's all for CBC, and then we move for serum creatinine. Actually, it's called kidney function test. So creatinine and urea, and then other investigations. Here I put all investigations. So we have to divide the investigation into lab investigations and radiological investigations, or lab and imaging. Lab wise, we need to do CBC. الكلام هذا مهم يا جماعة. CBC or complete blood count, and we have to do LFT or liver function test, and we have to do kidney function test, and we have to do coagulation profile for each patient, PT, BTT, INR, and we have to do serology or virology for hepatitis B, hepatitis C, and at least HIV. At least those three viruses we should screen. We should screen it before surgery. Okay. So again, اكتبوها يا جماعة ما هي مكتوبة. I don't think that I wrote that in my in the following slides. So هذا السؤال المفروض انك ما تسأله يا احمد. انت طالب في كلية الطب، يعني احتمال يجيك من اي مكان، سواء من السلايدز او من برا السلايدز. عموما again CBC or complete blood count، عندنا liver function test, kidney function test, coagulation profile including PT, PTT, and INR, وعندنا serology. Okay, so this is regarding the laboratory investigations. What about the uh, um, uh, imaging studies? We should do X-ray for every patient who will have general anesthesia, chest X-ray, and ECG for those who are older than 40. So 40 and above, you should obtain ECG. Okay. So what I wrote here: ECG, chest X-ray, urine analysis is not important. Blood glucose and hemoglobin A1C for diabetic patients. Others like coagulopathy, beta HCG, especially for women before going any surgical. This is medical legal. So, woman, I mean, woman in childbearing age, you should you should obtain beta HCG before any kind of surgery, even for local anesthesia. You should obtain that exam, okay, or that test. ABG is not important. Liver function is important. Relevant investigation to assess capacity of specific organs. يعني ممكن نحتاج مثل ما هو مثل ايش مثلا نحتاج ايكوغرافي والله في البيشنت with ischemic heart disease for example. We need to do cardiac echography to assess the ejection fraction for example. Okay, we need to do for example ايش مثال اخر uh, respiratory function test for those who will undergo uh, uh, lung resection, for example. So we should do respiratory function test before surgery. Okay. Okay. طيب هنا preoperative management of patient with systemic disease. You should refer the patient يعني هنا انت لازم تعرفها ك ك ك كطالب في كلية الطب that you should trigger each comorbidities and you should treat it well or prepare the patient well before surgery, like diabetes. If the patient is diabetic, you should know if his blood sugar is well controlled before surgery. Patient with hypertension, you should know that, or you should optimize the treatment of hypertension before going to surgery. Okay, unlike this. In emergency, now we are that's regarding the elective cases. In emergency cases, you should know something. You should know it's not the same. For example, for the history, if you have a life-saving patient or a top urgent case, you will not have much of time to go through the previous history and exam. So there is a certain question that you should ask the patient before surgery. For example, if the patient is in PO or not, when was the last meal, previous surgeries, drug history, and comorbidities. That's more than enough. So in case of emergency, you have to ask about uh, the last meal, drug history, previous surgeries, and comorbidities, and then you can proceed for lab and other investigations. Sometimes in life-saving patient, for example, the patient came to you, he is unconscious, or GCS is about 7. So he cannot speak, for example. In this should I obtain I can obtain the history. We can obtain the history from the relatives. I mean, هذا يهمنا في الكونسنت, especially في الكونسنت. الكونسنت is important for elective cases and emergency cases. No one is allowed to enter uh, uh, no one is allowed to enter the OR, or no one is allowed to be in the OR without surgical consent. يعني إذا ما وصلت لهم سدد وقارب يا عبد الإله. سدد وقارب. You have to obtain as much as you can informations from relatives, from the patient, from the surroundings. Okay. طيب. Risk assessment and consent. This is a very important slide Risk related to the comorbidities, anesthesia, and surgery should be explained in details. Explain advantage, side effect, prognosis, and alternative of surgery. You should also explain the alternative for surgery. The language should be simple. Use daily life comparison to explain risk. You have to be easy with patients. You have to be simple. Okay. Consent. Valid consent is necessary except in life-saving circumstances. In life-saving patient in pleading, you don't need to to have the consent. So you are the one who decide to to shift the patient immediately to the OR for urgent exploration. So in urgent cases, or not in urgent, in life-saving cases, you don't have to obtain consent. Okay. So regarding the consent, it should be valid, implies that it's given voluntarily by a competent and informed person who is not under stress or under duress. In emergency situation or in unconscious patient, consent may not be obtained, and the procedure carried out in the best interest of the patient. So as I said, in elective cases, that you should obtain the consent and the proper consent. I mean, the name of the patient should be clear, the procedure should be clear, the name of the procedure, the complications, and the anesthesia consent as well. So we have in the consent we have surgical consents and we have anesthesia consents. That's that's the part of the anesthesia job. It's not our part, but in our surgical consent, you should have the name of the patient clearly written, his signature. You should explain you should write the name of the procedure, and you should write also the complications that possible could happen after surgery. So the operative team, from the ward we have ward, theater, and specialists, nursing staff, anesthesia and surgical team, radiology, pathology involvement, radiology specifically or especially in orthopedic cases, and pathology. Pathology, for example, for frozen section histology, we need to have a pathologist in the room. Okay. Rehabilitation, social care after surgery, and other persons. Arranging the theater list. For arrangement of the list, the children or kids that uh, uh, um, those that cannot be fasting for more than 6 hours or for more than 9 hours, you should put them in the top of the list. Kids, patients with cancer, or major operations. Major operation, it should be the first of the list, and the beginning of the list. Kids, and for example, cancer patients. So the date, place, time of the operation should be matched with the availability of personnel. Appropriate equipment and instrument should be made available. لازم تتأكد من كل الانسترومنتس قبل ما تدخل أي مريض، والايكوبمنتس حقك كلها تكون جاهزة. The operating list should be distributed as early as possible to all staff who are involved in making the list run smoothly. Priorities patients زي ما قلت children, diabetic patient should be placed at the beginning of the list. Life and limb threatening surgery should take priority. Cancer patient as well. Okay. Special consideration: nil per mouth or nothing per oral, and regular medication. The patient should be fasting at least 6 hours of solids before surgery and 2 hours of liquids before surgery. Okay, so the patients are advised not to take solids within 6 hours and clear fluids within 2 hours before anesthesia to avoid the risk of aspiration. Okay, aspiration pneumonia is one of the catastrophic events that could happen for the patient post-operatively with very high mortality rate. Okay, infants are allowed to take a clear drink up to 2 hours before surgery, mother's milk up to 3 hours before surgery, and other formulas, other milk formulas up to 6 hours before surgery. Okay. Patient can continue to take their specific medication يعني اللي على antihypertensive يمشي عليها. الميديكيشن for diabetic medication we can shift the patient from metformin for example to insulin. Okay, so regular medication, uh, this certain regular medication should be continued before surgery. Okay, continue medication over the preoperative period, especially drugs for hypertension, ischemic heart disease, bronchodilators. Give the patient oral steroids therapy if the patient is taking hydrocortisone in large dose, for example, and you can shift him on intravenous one. Stop oral warfarin anticoagulation 3 to 4 days before surgery and do what's called bridging to heparin because the heparin has short half-life is around 4 to 6 hours before so we can stop this heparin 4 to 6 hours before surgery and we can proceed for the surgery. طيب أنا كده تقريبا خلصت. This is the conclusion and يعني أتمنى إنه المحاضرة تكون أو كانت خفيفة وكانت واضحة للجميع. The anticipated outcome of preoperative preparation is a patient who is informed about the surgical course, copes with it successfully. The goal is to decrease complication and promote recovery. طيب preoperative medication طبعا شابتر فيه كبير في بيل اند لاف بامكانكم الرجوع له تقروا منه. لا تعتمدوا على المحاضرات كما تقول لي. انا شرحت حقيقه الميجور بارت من ال من ال من السبجكت ده. دكتور ياسر ما زلت معنا؟ طيب في احد عنده سؤال استفسار من الان اسالوني اذا في سؤال استفسار، اذا في شيء مو واضح اساله. يعني حبيت انه يكون خفيف وظريف زي ما يقولوا. لو في اي شيء مو واضح تفضلوا يا شباب. الوارفرين لو كان بكميات قليله، ما في وارفرين بكميات قليله. ما في حاجه اسمها وارفرين. any warfarin should be stopped before surgery or should be bridge. يعني نوقف الوارفرين and we shift the patient on heparin because the الوارفرين الهاف لايف حقه 3 to 5 days. So we should stop warfarin and shift the patient to heparin, okay, till the INR became normal. So it will take 2 to 4 or 3 to 5 days. Okay, so any warfarin should be stopped before surgery except for life-saving surgery. والله هذه لا حول ولا قوة. لو واحد جاني life saving for example bleeding or something like that and I need to intervene within 5 minutes, I don't have time. خلاص هذه يعني مجبرين على ان احنا ندخل المريض وهو على وارفرين. Yes, for warfarin we can stop the war. It's written there I think. Those on warfarin who have had life-threatening thrombotic events مثلا pulmonary embolism and he knew warfarin for 6 months, okay, وجاك acute cholecystitis for example, within the previous 3 months we should be switched to heparin intravenously until 6 hours before surgery. 6 hours before surgery you should stop that heparin. بمعنى المريض والله جاني مريض على وارفرين وعنده acute cholecystitis and I'm planning to operate on this patient. تمام، اوقف الورفرين، اقول له ما ياخذ وورفرين، اعطيه شورت اكتنج هيبرين وانتظر عليه 3 أو 5 ايام الى ما ينزل الاي ان ار بيلو 1.5. معناته ايش؟ معناته الورفرين بدا ايش؟ بدا يروح من جسمه. طيب انا حطيته على هيبرين، الان كيف ادخله العمليه؟ لا، ادخله اوقف الهيبرين عنه 6 ساعات قبل العمليه وبعد كده ادخل العمليه. الكلام ده واضح؟ هل الورفرين ولا كل انواع عندنا مثلا الانتي بليتس. عشان كده اقول لكم في شابتر في بلين لوف كويس الانتي بليتلتس. we can stop it immediately. We don't have bridge for antiplatelets. Antiplatelets زي بليفكس زي الاسبرين in large doses. Stop that medication and proceed for surgery. We don't have bridging. And post-operatively, you should cover the patient with a preventive dose of heparin. تمام؟ كل anticoagulants should be stopped or should be bridged before surgery to another medication that have a short half-life. It's wrong. Regarding the aspirin, I agree for you. I agree with you that certain procedure like nail extraction, you don't need to stop the aspirin on large dose for this little surgery. But for acute, for example, for major surgery, you should stop the aspirin with large dose, 300 and above. You should stop it before any major surgery. 19. يا جماعة ترون مو هي بالسلايدات. duties of the nurse. اها سوري. طبعا هذه في الهولدنج اريا وعندنا الاو ار مقسمه الى 3 اجزاء. ريكفري، عندنا الويتنج اريا اول ما يجي المريض في ويتنج اريا، في عندنا الاو ار، في عندنا الريكفري. تمام. So this is the responsibilities or these are job or this is the job of the nurse who will be in the waiting area to provide information and emotional support for patient with their family members to ensure that all preoperative data تتأكد من الاسم، تتأكد من رقم الملف، to maintain patient baseline hemodynamics، تتأكد من احنا نسميه endorsement ما بين الممرضات طبعا الممرضة تبع القسم هي اللي تنزل المريض عند الممرضة تبع الويتنج اريا في الاو ار، يحصل بينهم اندورسمنت، ايش اخذ العلاج، ايش العلاجات اللي اخذها، اسم المريض ايش، رقم الملف تاكدوا منه، متى اخر مره شرب، متى اخر مره اكل، وهكذا. So this is the endorsement between ward nurses and OR nurses. محاضرة جميلة يعني، وأي واحد لازم يعرفها، أي شخص لازم يعرفها، أي شخص أقصد أي جراح لازم يكون ملم بالأشياء. طيب في سؤال؟ طيب أنا بطلع من السيشن، وكل عام وأنتم طيبين ورمضان كريم، وانتبهوا من كورونا. الحالات صارت 4945 اليوم. من الاختلاط، لا تختلطوا بالناس، لا تطلعوا إلا وقت الضرورة. كورونا صار متفشي بشكل فظيع. آه، خافوا، إذا أنتم ما أنتم خايفين خافوا على أقاربكم اللي كبار في السن، والله المستعان. يلا في أمان الكريم. دكتور ياسر ما أدري معانا دكتور ياسر ما زلت موجود؟ دكتور ياسر طبعا له الفضل الكبير حقيقة في ترتيب الجلسة. يلا يعطيكم العافية، في أمان الله.